Hi everyone, I'm Aidan Fallman, and I'll be presenting Extended Compartmental Model of COVID-19, a cell DEVS definition. My co-authors are Dr. Christina Ruse-Martin, Dr. Gabriel Weiner, Peter Tobias, and Mark Rempel. A bit of an introduction before we get started. Why model the spread of disease? The quick, easy reason, understanding the spread of disease allows for faster and better response. Health officials can use models and they can design and change their response based on what the model is showing. If we have accurate models predicting that a disease is going to start rising significantly much sooner than we expected, we can implement those lockdowns and those mandates much sooner than we had originally planned, potentially stopping the disease before it reaches much, much higher peaks. The next main reason is to model emerging disease. So we saw that with COVID-19. COVID-19 was the latest emerging disease, but there's going to be more. It's inevitable. We're going to have a future pandemic eventually. We're going to have a new COVID-19. And if we have models that can model diseases and the spread of diseases, we can potentially reduce the damage that these diseases do in the future. And we can stop them before they get as scary as COVID-19 got in some places. Now, when we're modeling these and when we're looking at different diseases, there becomes some problems. And one of those main problems is the two different types of carriers and how they spread the disease. What these two carriers I'm talking about are symptomatic carriers and asymptomatic carriers. A symptomatic disease carrier is someone who has a disease and they have symptoms. So in the context of COVID-19, a symptomatic carrier would be someone who has COVID-19 and they're coughing, they have a fever, shortness of breath, and all the different symptoms that come along with that. An asymptomatic carrier is someone who has COVID-19 but has no symptoms, and therefore they don't know they have COVID-19. Now the problem here is both of these carriers spread the disease. So we would ideally want to stop asymptomatic carriers before they spread it. But what data exists for asymptomatic carriers? Now that's the biggest problem. If an asymptomatic carrier doesn't know they have COVID-19 and they don't have symptoms, why would they go get tested? If they're not going to get tested, we don't know they have COVID and we don't have any data for them. Now, one of the few ways that researchers have been able to predict and see how many asymptomatic cases are in a population is to test the entire population. The problem here is data changes over time. We have different variants of COVID-19, potentially with higher asymptomatic rates. Researchers have studied and found that asymptomatic rates in a population can range from anywhere from 5% to 80%. So we need a way of modeling all these different possibilities. And that's our contribution here, a cell DEVS model for rapidly prototyping disease spread where asymptomatic infections have been incorporated. Now, some background on disease modeling before we get started on our contribution. Most disease modeling stems from the standard Susceptible-Infected-Recovered model, or the SIR model. In an SIR model, the population is divided into one of the three states, the states being susceptible, infected, and recovered. The susceptible population becomes exposed to the disease, moves to infected after a given period of time. The infected population will then eventually recover, where they cannot regain the disease, and they are immune to it. Now this model, it worked for some diseases, but it's been changed and adapted over time to incorporate more advanced states and more advanced transitions, allowing for different things, which we'll talk about in a minute. Now, the SIR model in today's world has generally been used and has been modeled using cellular automata. Cellular automata is a modeling method where space is represented as a lattice of cells where the neighborhood can be user-defined. What I mean by this is we have these three figures here. These are three different types of neighborhoods we might see in a cellular automata model. They can be as simple as this one here, and then we can add a little bit more and more. Depending on what the model needs, we can define different neighborhoods. In these models, each cell can be represented as a finite state machine, and the cells transition from one state to another based on their previous state, as well as the neighboring cell's previous state. Now this is shown to work well for SIR models, but over time we needed something more advanced. And the cellular automata models have shown to be a bit computationally heavy. They have reduced precision, especially in time, and they have some integration problems. They don't always integrate well with other tools. These are the main motivations for using CellDevs. CellDevs is a combination of cellular automata and the discrete event systems specification. Now, in cellular automata, each cell is defined as a DEVS atomic model, and the entire cell space is defined as a DEVS coupled model, where each cell is interconnected. So we still have that cellular automata way where each cell is interconnected and its neighbors are connected to each other, but now each cell can be represented by a DEVS atomic model. Now, CellDevs inherits the modularity and hierarchical modeling from the DEVS formalism, and this allows us to integrate with other tools much easier. Now, in CellDevs, we were able to create more advanced models. One of these models incorporated a geographical cell space. What a geographical cell space is a model where the cell space is no longer a simple lattice of cells, but now we have a geographical based cell space where our cells are these different regions. Now, this can be called an irregular shaped cell space, but we still need a way of correlating each cell to its neighboring cells. How do we know what cells are neighboring each other? And this is where geographical correlation came in. Now, geographical correlation can be shown as I'll show an example here using the wards of Ottawa, where each cell can correlate to its neighboring cells based on their borders. So if we take a look at this cell here in the middle in green, it has 3 neighbors. Now, the length of the border defines how much of a relation it has to its neighbors. So the base cell here has a correlation with its neighbor here in 1. It has a slightly higher correlation with number 2, but it has the most correlation with its neighboring cell to the south, cell 3. Now, using this model, we had new models come out of this. So using a geographical model, we could incorporate a disease on a geographical level. One of these is the SEAIRD model, which we can see here. The SEAIRD model is the susceptible, exposed, infected, recovered, and dead. So what this model incorporates now is a transition from susceptible to exposed before a population becomes infected. And the infected population can now either recover, or if they don't recover, they will die from the disease. Now, this allows for different modeling, and we can now model the mortality of a disease before the disease has shown what its mortality is. And this can allow us to quickly stop a very dangerous disease quicker. Some of the shortcomings of these models, though, is they lack asymptomatic representation. And as I mentioned earlier, asymptomatic representation needs to be considered, as these people are still spreading the disease even though they don't know. And that is where the SEAIRD model we are presenting comes in. Now, in this model, we have incorporated the asymptomatic state, where now we have a new transition from exposed to asymptomatic. So the susceptible population becomes exposed, and then they either become infectious or asymptomatic. The asymptomatic individuals or population can then recover, and the infectious individuals will recover or die from the disease. We do this as asymptomatic individuals generally will not die to COVID-19, as the main thing that is causing death in COVID-19 is the symptoms or complications due to the symptoms. Now, in our model, each state's transition is defined by the state's unique time behavior. So each state has a different set of time behavior. What this looks like in this diagram is under the exposed, asymptomatic, infectious, and recovered state, we have day 1 until day T state. So E, AI, I, and R. What this is doing is on each day in each state, the population has a chance to move to the next state. So on day 1, the exposed population has a small chance to move from asymptomatic to infectious. And then on day 2, the remaining population has a chance to move again, and 3 and 4 and so on. And each of these, we've done some research to try to find the best values for these, and that's discussed more in the paper than we'll discuss here. But we've defined these based on some research we've done to find the exposure rates, the recovery rates, and the fatality rates, and so on. Now, with this, we can now discuss the infectious and asymptomatic effect of this model. But first, how do we add asymptomatic populations to this model? The first thing we need to consider is the asymptomatic rate. So how many asymptomatic individuals are within a population? And how we approached this problem was using a asymptomatic infection rate. We chose to define asymptomatic infection rate because we wanted to prototype asymptomatic infection rates. As I mentioned earlier, some studies have shown the rate of asymptomatic carriers in a population could be anywhere from 5% of the population to as high as 80% of the population. So we needed a way to test all these different levels of asymptomatic carriers, but in one model. And that's why we chose to use an asymptomatic infection rate. It's easily adaptable and it allows for rapid prototyping. So now we can take a look at how these new populations are affecting the susceptible population and the transition from susceptible to exposed. So how are asymptomatic carriers spreading the disease? We know they are, but we need to think about how they are. How are they spreading it? Who are they spreading it to? And the approach we took here was the asymptomatic carriers, we are considering them spreading it the same as the infectious carriers, but with a little less care. An asymptomatic carrier doesn't know they have COVID-19, so they may spread it to those around them easier. They don't know they have it, so why would they avoid their friends and family? So because of this, our approach was to define an infection correction factor. The infection correction factor is the disobedience factor between cells I and J. Now, what that means is if cells I and J, which is two neighboring cells, have different levels of lockdown or restrictions. So for example, if cell J, you had to wear a mask at all times, but in cell I, you didn't, we're considering the higher restrictions to be the infection correction factor. And then the disobedience factor between these two is the chance for the population to ignore those restrictions. So if a given population has 50% of them will ignore the restrictions, then 50% more individuals have a higher chance of exposing the susceptible population. Now, how we took asymptomatic populations into account here was we assumed the asymptomatic population would spread it a bit more carefree. So they are ignoring the infection correction factor and they are moving around as if they are fully disobedient. Now, this is because the asymptomatic carriers don't know they have it, so they aren't going to be as worried about wearing a mask. When they're outside, they may not bother wearing a mask. They don't have COVID. They don't think they have COVID, at least. So why would they change their daily life? So in this approach, asymptomatic carriers continue to spread the disease without knowing it at a higher rate. Now that we've discussed this, what does this actually look like when it comes to running and viewing the model? First, we need to discuss how the model is implemented. The model has been implemented as a parameterized model. So the model takes in a bunch of different parameters that define the disease, the population, and so on. Some examples of these parameters include asymptomatic infection rate, incubation rates, mobility rates, recovery rates, and fatality rates. I mentioned some of these earlier, and these describe how the population will transition from state to state. So depending on the asymptomatic rate, that percentage of the population become asymptomatic, the remaining become infectious. It's quite simple and allows for easy modifications. With our parameters made, we can then run the model. An example of us running the model here is using a case study of the Ontario Public Health Units. For this, we ran a couple different scenarios to view how the model would run using different asymptomatic rates. The first scenario here is using 0% asymptomatic carriers. Here we can see the wave begins just before the 100th day and it settles a little over and around 350 days. We can see a steady rise of infectious cases and a steady fall, and the same goes for our exposed individuals. Now, if we look at how this compares to a scenario where we have much more asymptomatic carriers, we can see here in scenario 2, with 80% asymptomatic carriers, we have quite different results. The wave still begins around the 100th day, and it continues to have an increase and then a decrease, but we can see here it increases much faster and decreases faster, now ending around the 250th day. what we can immediately see is that infections continue to rise and fall, but now we have this large spike of asymptomatic cases, and they do the same thing as infectious looked before. So we have a shorter wave, but higher peaks. So with this, we can compare the two and we can see the differences between them. What we can right away see, we have much higher rates of exposures when we have more asymptomatic cases. This is because of what we talked about earlier, and those asymptomatic carriers are exposing more individuals, but they do not know it. So we have higher rates of infection, but these infections aren't as lethal, so they're not causing as many deaths. But there is some scenarios where this can change. And that's what we're going to look at next. We're going to look at a scenario where we look at a specific neighborhood and then discuss why this is important. So here I've taken a single neighborhood and I'm comparing on the same day these two different cases. So this is a single neighborhood in our Ontario Public Health Unit where on day 133, the difference between 0% asymptomatic carriers and 80% asymptomatic carriers is quite significant. Immediately we can see around four times the number of exposed individuals, but we have less deaths. So why do we have less deaths? We've already discussed this. We have more asymptomatic carriers, and those asymptomatic carriers cannot die. So our deaths will become lower than a case or a scenario with 0% asymptomatic carriers. But we need to consider other demographics here. So this is one neighborhood. What about a neighborhood that's primarily dominated by an elderly population or an at-risk population? These asymptomatic carriers may not end up being asymptomatic if the population was dominated by an elderly population or an at-risk population. If this was the case, those infectious individuals who are at risk may die to the disease, and this would lead to higher fatalities. So although we're seeing lower fatalities in this scenario, this might not always be the case, and it may not hold for every other neighborhood or every other scenario. And that's why we built our model like this, is it allows for the user of the model to input different parameters and different age groups, and they can model all kinds of different scenarios, not just simply a 0% asymptomatic or an 80% asymptomatic. So with that, some conclusions to our model. The SEAIRD model we're proposing allows for rapid prototyping of asymptomatic carriers. The model performance provides quick turnaround when rapidly prototyping. So for what I mean by this is when you're running the model and you're changing things, you'll get quick turnaround, so you don't have to wait for results. The runtime is approximately 30 seconds when we were modeling 14 public health units with 500 time steps. In our case, those 500 time steps represented 500 days, and this all ran in 30 seconds. With the model running that quickly, though, you have to be able to adapt it quickly as well. And the model allows for easily adaptable disease dynamics. These disease dynamics can range from just different variants. So different variants can be modeled with minor changes. You can touch the virulence rates, the incubation rates, slightly change the disease dynamics, or you can model entirely different diseases with slightly more changes, but it's still very quick. You can do most of this within 5 to 10 minutes if you have the disease dynamics ready. And with that being said, that is the end of our presentation. Thank you.